Our case study this week is on the third trimester by Erica, Wendy, Kathy, and Nicole. A woman in her third trimester is considering whether or not she wants to receive the pertussis vaccine in pregnancy. The questions we will answer are, what are the current recommendations regarding this vaccine in pregnancy? What kind of research guides this recommendation? And how would you present this information to your patient? What are the current epidemiological statistics around pertussis in pregnant women and neonates? We will also describe the pathophysiology and clinical manifestations of pertussis in neonates, and we will also talk about how the condition is typically managed and what the prognosis is. Pertussis is also known as whooping cough. Pertussis is a highly contagious respiratory tract infection caused by the bacteria Bordetella pertussis. It is spread by close contact with droplets of an infected person. This person can be infected for 3 to 5 days without knowing it. Pertussis is known as whooping cough because of the hacking cough followed by a whoop sound with air intake. It is common in young children and infants and unfortunately more severe when they get it. When adults and older children get it, it is not as harmful. The pertussis vaccine changes depending on the age you get it, but it is either DTaP or Tdap. It includes pertussis, tetanus, and diphtheria. There are 6 primary doses of DTaP given at 2 months, 4 months, 6 months, 15 to 18 months, and 4 to 6 years. DTaP is stronger than Tdap because the immunity needs to be stronger for the initial vaccinations. The last Tdap given to complete the 6 primary doses is given at 11 to 12 years. From there, a booster is recommended every 10 years. However, this changes during pregnancy. It is recommended by the CDC and ACOG to get the vaccine every pregnancy regardless of the last time it was received. It should be done between weeks 27 and 36 of pregnancy. If it is given earlier than 27 weeks, it should not be given again later on in the pregnancy. There has been a lot of research on the pertussis vaccine in pregnancy, especially because the incidence in the United States has risen. Infants are at risk of death if they get whooping cough. By getting the vaccine in the last part of pregnancy, the mother passes on antibodies to the infant. Since infants can't get the first vaccine until they are 2 months old, they depend on the passive immunity from their mom. 2 weeks after the vaccine, either maternal or infant, antibodies are developed. The antibodies are shorter lived, so it is given later in pregnancy to ensure the antibodies also protect the infant. Fewer infant hospitalizations and deaths happen if the vaccine is given during pregnancy instead of in the postpartum period. All of the information regarding pertussis and the effects on newborns should be given to the patient, as well as how long it takes to build up immunity, the best time to receive it, and what statistics and prognoses are for infants that contract whooping cough. This picture shows a simple way of how the vaccine helps protect her baby.
Looking at epidemiological statistics of pertussis, these statistics are simply from are only from the United States. In 1940 to 1945, during a 6-year period, there were 1 million cases of pertussis reported, averaging about 175,000 cases per year, or about 150 cases per 1,000 population. The whole cell pertussis vaccine was introduced in the 1940s, and there was a continual decline in the incidence of pertussis after that. In 1960, there were 15,000 reported cases. In 1970, there were less than 5,000. And then between 1980 and 1990, averages of about 2,900 cases per year. Since the 1990s, however, there was a gradual increase that has been observed in the U.S., with the peak incidence happening in 2012 of 48,277 cases. There's some thoughts as to why this increase has happened. There's probably a lot of different factors contributing to it, but there might be changes in testing, or there's a heightened recognition of it, and reporting. So more people are reporting that they have pertussis. There might be, there's also thought that the waning of the vaccine-induced immunity is playing a role in making so that there are more cases. This is a chart I found on the CDC website that kind of gives a visual of the trends from 1990 to 2019 on the incidence of reported pertussis. You can clearly see there was a spike in 2005, and then again you see that larger spike in 2012. And since then it has again kind of declined. Of course, as we know, infants less than 1 year are the most likely to get pertussis, and they continue to have the highest rates of whooping cough. The incidence in 2018 among infants 0 to 6 months was 72.3 per 1,000 population. In the age range of 6 to 12 months, it was 32.7 per 100,000. And the incidence of pertussis in women, I found a study that specifically looked at women aged 29 to 33 from 2012 to 2017 in the United States. Pregnant women, the incidence of pertussis in pregnant women was 7.7 per 100,000. In non-pregnant women, it was 7.3. So it was comparable with pregnant or non-pregnant women. And then the reported deaths of infants due to pertussis. In 2012, there were 15 deaths reported of infants that aged less than 3 months. In 2016, 6 deaths in infants less than a year. And in 2020, there were 3 deaths in infants less than a year.
Pathophysiology in neonates. Bordetella pertussis and Bordetella parapertussis are the causative viruses of pertussis. They are spread by airborne droplets. They are highly contagious and often affect 100% of non-immune victims. Immunity wanes to 5% 12 years after completed vaccination. The immunocompromised can also contract Bordetella bronchoseptica, also known as kennel cough. Bordetella is a gram-negative coccobacillus. It adheres to the ciliated respiratory epithelial cells, which causes inflammatory changes in the mucosal lining of the respiratory tract. The toxins are then released and act locally and systemically, but they are rarely found in blood cultures. Clinical manifestations in the neonate: cough, coryza, afebrile to a low-grade fever, apnea, seizures, cyanosis, emesis caused by coughing, pneumonia, increased white blood cells, rhinitis, and a high-pitched cough, otherwise known as the whooping cough.
Moving on to management of pertussis. In healthcare settings and in families with newborns, prevention of secondary cases is crucial. The first dose of the vaccine can be given as early as 6 weeks of age, and an accelerated schedule is advised for children less than 7 who have not finished their basic vaccines. Antibiotic prophylaxis should also be given to close contacts. In these situations, the CDC continues to advise erythromycin as a preferred medication or the first-line medication, with the exception of newborns 2 weeks of age or below. Neonates are not able to take this. For the purpose of preventing pneumonia related to medical care, the course of therapy should be longer than 14 days. For people who cannot take erythromycin, azithromycin and clarithromycin should be used to treat patients who are intolerant or newborns who are too young to receive the medication. After 5 days of antimicrobial therapy or 21 days if unable to take antibiotic, patients are said to be non-contagious. Other forms of management are if infants get pertussis, they are normally hospitalized because babies aren't able to cough and clear their lungs, so normally newborns end up in the hospital. Moving on to prognosis of pertussis. Pertussis remains a significant cause of morbidity and mortality in infants younger than 2 years. Infants are at higher risk of severe illness requiring hospital admission, complications, and death. Death from pertussis is inversely related to age, with almost 90% of reported deaths occurring in unvaccinated infants less than 1 year old, who have case fatality rate of 0.6%. High levels of leukocytosis and lymphocytosis may predict a fatal outcome in children admitted to hospital. Babies who have whooping cough may have significant, even life-threatening consequences. Within the first 6 months of life, this is particularly true. It's crucial to understand that a lot of infants with whooping cough don't cough at all. They instead cease breathing and become blue as a result. Babies who have whooping cough are hospitalized in about half of the cases. It is more probable that a newborn may need hospital treatment if she contracts whooping cough at an early age. 1 in 4 infants who receive whooping cough therapy in a hospital may develop pneumonia, and 1 or 2 infants out of every 100 will pass away. Other issues include erratic, violent shaking, life-threatening breathing pauses, and brain illness. According to the CDC, since 2010, CDC sees between 10,000 and 50,000 cases of whooping cough each year in the United States. In fact, there are cases reported in every state. 2012 was a record year with more than 48,000 cases, the most cases that CDC has seen in the past 60 years. Most of the deaths each year are in babies younger than 3 months of age. Since 2010, up to 20 babies die from it each year in the United States. Even though it seems like these are a lot of cases, the United States no longer has 200,000 cases per year like it did before the whooping cough vaccine was available.